right, so we're talking about knee dislocations, and the sports theme of that is really essentially multi-leg injuries. So, and this is the caveat. This is for you beginners or novice junior surgeons, but actually it's really for both. It's the same kind of concepts for all levels. Okay, so first of all, let's talk a little bit about just the ligaments. Okay, in terms of the basic anatomy. So let's see, hard for you to see who's on here, but let's get an intern. How about the person known only as Cas and nothing else? What do you think is the strongest ligament in the knee? So I'll give you four choices: ACL, PCL, MCL, and LCL. Which one of those do you think is the strongest?
Oh, you cut out there for the multiple choice option, but I heard
Oh,
ACL, PCL.
LCL or MCL. So those are the four main choices.
I'm gonna go ACL.
Okay, so that's probably a good guess, but it's not the right answer. The ACL is frequently injured, okay, but the MCL, if we look at biomechanical testing, is actually the strongest ligament. So if you're looking at valgus stress, it's about 4,000 newtons of force for the MCL, okay? And then if you're looking at the second strongest, that's the PCL, and that's about 2,500 newtons. And then if you look at the third, that's ACL, so that's 2,200 newtons. So that's one of the reasons when you have a traumatic injury to the knee, the ACL is frequently torn. Of course, it depends on mechanism and the directionality and everything, but the ACL is not very strong. And then if we keep going from there, the posterolateral corner complex, it's made up of three separate things. You got the LCL, popliteus, and the pop fib ligament, and altogether they add up to be like 1,300-ish or so. So that's not a super strong structure, but that's really more for rotation. So unless you're doing a specific move, it's not that easy to get the PLC without a high level trauma. And then if you look at the LCL just by itself, that's actually the weakest one. If you're just going to do direct varus stress on it, that's only 750 newtons. So it's the smallest one, and MCL is like much bigger. There's a superficial and a deep layer, so we'll talk about the anatomy a little bit, but that's actually the strongest one, and that's also the one that heals pretty well. So we seldom have to do surgery on the MCL. Okay. All right, so this part's really important, especially for any residents that are taking ER calls. So when you have an injury like a knee dislocation, you typically think high-level trauma, right? Like big car accident, multi-system trauma. But for some people, it could be a very, very low trauma. So let's see, Alex. What kind of population can have a full-on knee dislocation without much trauma?
Like people that are obese, I think of
Yeah.
having like dislocations pretty easily.
Good, good. So you have a morbidly obese patient. They said, "Oh, I just took a misstep on the sidewalk, but I can't move my knee, and it's super painful." You get an X-ray, and their knee can look just like this on that X-ray. Okay, because of the body habitus and poor muscle control and just various factors. Morbidly obese patients, very high likelihood for just a full-on knee dislocation without much trauma. Okay, and then of course the knee dislocation, if you see an X-ray like this, it's going to be typically associated with multiple injuries. Okay, what's the most common injury that's associated with a knee dislocation? Anthony?
Think about an injury to the perineal nerve or the popliteal artery.
Sure. So nerve or artery
So,
injuries
yeah.
are common, but actually it's most common to have an associated fracture, okay? Because most of them are high energy injuries. Most of the time, if you have a knee dislocation, there's a fracture somewhere, whether that's plateau or femur or ankle. So about 60% of the time they're associated with fractures. Nerve injury is something we worry about most, but that's also pretty high considering, but it's about 25%. And then the perineal nerve is much more common than a tibial nerve injury, okay? And then vascular compromise, even less common, 5 to 15%, but still much more common than any other limb injuries that we would see potentially from an orthopedic standpoint. And then soft tissue injuries, patellar tendon, menisci, those can happen, but they're less common as well. Okay, so these are all the things you want to look for: fractures, nerve, and vascular compromise. Okay, treatment. Oh, classification. Okay, before we get to treatment. Okay, so let's see, Sergio. how do we classify knee dislocations?
Um, I'm not exactly sure. I actually was just looking this up. But there's the Schneck classification based on the number of
Yeah.
ligaments out.
Yeah, and then I think probably the easiest one is kind of the Kennedy one, which is based on direction of the tibial displacement. So typically, this is pretty easy to describe when you're talking to your senior or you're attending about it. I mean, from the junior level, if you guys see one of these in the ER, these are some of the things you want to think about. So in terms of the directionality, so which way the tibia is. So if the tibia is anterior, this is actually the most common um, classification or most common pattern. And it's usually a hyperextension injury. And then these can be associated with PCL tears, intimal tears of the artery, popliteal artery. And then it also has a high rate of perineal injury just because it's a hyperextension stretch injury. Okay, so these are typically what you're going to see most commonly. And that's where the tibia is anterior to the femur. The posterior displacement is the second most common. That's what the picture I had on the previous slide. And these are going to be more like dashboard injuries, the knees flexed, and then there's a posterior force. This has the highest vascular injury because there's a direct force posteriorly. And these you might be worried about like a complete popliteal artery tear. So these are going to be traumas like the posterior ones. The anterior ones are probably going to it could be more lower mechanism injury in terms of like the obese patients where they hyperextend and the tibia pops out anteriorly. Much less common are the lateral ones, lateral or medial displacement. These are kind of varus valgus. These are probably more like really bad sports injuries like football injuries. Some of these highlights you see on YouTube where the football player gets tackled and their knee gets completely dislocated. These are probably either more medial or lateral because you have to have that direct force from the opposite side to do it. And then rotational injuries are the least common. That's where you rotate it out and then the condyle is like pushed through the capsule and then you can't really reduce these. So that's pretty uncommon, okay? But it's something to watch out for based on your x-ray, okay? All right, so now we've gotten our diagnosis, we saw it. Syed, what do you do for treatment? You're the R2 on call coming up soon.
Yeah, so I think immediately before I do anything, I just want to get in a quick exam, see what their neurovascular status is before. And then I think the first line treatment is really just to reduce the knee to get it back in as soon as possible.
Exactly. Yeah. So yeah, you do a quick neuro exam. Everything looks okay. And then what you want to do is reduce it ASAP. So reduce immediately. Most of the time, well, you want to first try closed reduction in the ER. So depending on the direction it is, if it's anterior, you want to try to flex the knee and with the posterior force. If it's posterior, you want to try to kind of do like an anterior drawer and extend the knee. And most of the time it reduces pretty well if it's anterior posterior. If it's not rotational, it's not buttonholed, it can usually reduce pretty well with some relaxation. Now, if you can't reduce it under closed reduction, then you can take up to the OR for an open reduction, but that's less common unless there's something that's stuck. But then once you reduce it, the next step would be potentially X-fixing it if you need to. Okay, so if you're in the OR, if you have to go to the OR to do an open reduction, you're definitely going to need to X-fix it. If you do a closed reduction in the ER and they come back pretty nicely, you may not need an X-fix. So this is a very important teaching point. So Joey, so you just did this great reduction on this obese lady and it came together nicely. You pulled it up, it's totally reduced. The x-rays post-reduction look perfect. Her pulses look good distally now. What do you do? As a low energy mechanism, all her other systems are fine. What's your next step in terms of her management?
So I think initially, I think you can kind of range the knee after you've reduced it to see if it's still kind of grossly unstable. And it's probably hard to get a good ligamentous exam at this point, but I would say if it is still kind of grossly unstable, that would push you more towards, X-fix.
Sure.
But if it feels stable and full range of motion, then I think possibly you could do like a knee immobilizer.
So, okay, yeah, so you can get her kind of ranging from like 10 to 50-ish or so safely. And so what do you want to do for her dispo?
I would probably, you know, if I was at the county, I would probably just lean towards admitting her and watching her. Maybe do serial ABIs.
Mhm.
One question I had is before, let's say before we close reduce, like in the ER, should we be getting like a baseline ABI so that after we reduce, we can check it again and then check, you know, serially? Or do we just
I mean, you,
get it back in ASAP?
yeah, you just want to get it back in and then do your ABI, okay?
Right.
And usually they're pretty uncomfortable when it's dislocated. I mean, the whole situation here is most likely like a lower mechanism of trauma. If it's like a multi-system trauma, you're gonna just, you know, worry about all the other things, get it in, and then take care of all the other major traumas. But let's say it's like an isolated knee dislocation, then you want to just get it in and then do all the testing afterwards. But I think it's really important here for everybody to pay attention for these, even if it's a low energy mechanism, isolated knee dislocation, you reduce it, even if it looks perfect and feels stable, you can't send them home. Okay, because that's a lawsuit right there. Okay, do not discharge home because you need to check them for at least 24 hours because injuries can happen after the fact. Okay, you can get a DVT, you can have an intimal tear, and then you can miss like an artery injury. And you know, it happened right here two maybe 3 years ago. One of the R2s sent a dislocation home, and then they showed up in my clinic a week later, and they had arterial injury. Thankfully, nothing bad happened, but they had an arterial injury, nerve palsy, and an ulcer from the knee immobilizer. So these are people you guys need to make sure that you keep at least for 24 hours for observation. Okay, and this is for serial vascular exams. Typically, we'll do an ABI and then do it every 6 hours or something like that. I mean, for the first 24 hours, and then at least in-person exams on limb function. And then some people will just do a CT angiogram too. So check with your attending about that. So if there's a high suspicion, we'll just get a CT angiogram right away before anything else. But if everything feels safe, usually we'll just do serial exams. And you want to make sure the ABI is greater than 0.9 for 24 hours. Okay. If it's less, then you for sure will go to an ultrasound or a CTA, and then possibly consult vascular if there's anything going on. Okay. So that's an important thing. And then also neurologic exam. You're not going to do anything for the nerve. I mean, there's a high chance they're going to get a perineal nerve palsy or foot drop, but then you can at least put them in an AFO brace before they go home, just to help stabilize them. Because the patient came into my clinic with like a week-long foot drop with nothing going on. So and she's already starting to have an equinus contracture. So, and then the ligamentous exam we can focus on last, because I mean, that we're going to reconstruct at some point. It's seldom for a knee dislocation we're going to go in there and just repair it, because usually there's so much other stuff associated with it. So usually we just do delayed reconstruction for multi-ligament injuries for knee dislocation. Okay, so that's an important teaching point. Definitely make sure to not just send these guys home, no matter how safe they look. Keep them for 24 hours. Okay. Okay, good. Yep.
MRIs for these folks while they're in house. I guess the timing probably doesn't matter, but
yeah. Usually no, because it's pretty hard to get like a non-important MRI at Parnassus, or I don't know how it is at the general, but we can usually get those as an outpatient later on. We're not going to be doing their ligament reconstruction for a few months anyways. So, yeah. Okay. All right, good. Okay, so questions? Yeah, sorry.
We actually have a patient who came in yesterday with the knee dislocation at the general. A question about the end, who got an X-fix. In terms of like timing to take off that X-fix, do you keep it on generally until you do like a definitive reconstruction, or do you like transition to immobilize your outpatient?
So usually they'll scar in pretty well. Okay, so they're going to get pretty stiff. So these are the patients that get both stiff, that they're both stiff and loose at the same time, which is weird, but they have like, what they'll have is like a limited, like a little flexion contracture where they can't get fully straight because of all the scar tissue. And then their range of motion is going to be like 10 to 80. And then you do an ACL and it's like a 2B, and you do a posterior jaw and it's like totally loose. And then varus and valgus are like grade 2 and 3. So like their ligaments are all gone, but then their range of motion is very poor because they have arthrofibrosis. So what you want to do first is keep them in the X-fix. variable timing, like until I mean, is it an isolated knee dislocation, or is there other stuff going on?
Yeah, the reason why he got the X-fix is because he had a popliteal artery segmental injury, so a vascular went in and did a shunt.
Yeah.
But he was like the classic morbidly obese, most likely anterior dislocation, and with an arterial that
Yeah. So then you defer to them, because then a lot of times you need that X-fix to help protect their shunt. Okay. So that X-fix might stay on for a few weeks. Okay. And then they're going to be super stiff, and then you just work, and then you take the X-fix off, and then you work on PT and getting their range of motion back. And then you do the reconstruction like a year later. That's when you send them to Dr. Lansdowne's clinic for that. Okay. All right. Good. So it just kind of depends on the situation, but usually we're not going to be doing the sports part for a while. Okay.
Are we doing
okay.
Are we doing these patients home on like anticoagulation or things like that too after?
Yes.
Like
yeah, it's a very high risk for DVT. So, I mean, but if they do a shunt, they're going to be anticoagulating that anyway, so you can defer to them. But let's say there's no, let's say ABIs have been normal, I would still send them home on like Lovenox for at least a couple of weeks anyways. Yeah. Okay. All right, good. Any other questions about that before we go into more sports stuff? Okay, good. So now
I do have a question about like when you're talking about the initial exam. I guess my thought is, I mean, how much are you doing that initial exam once you relocate them? Like I kind of thought you just kind of reduce them, put them in the immobilizer, make sure pulses and ABIs, because they already have ligamentous injuries because they wouldn't have dislocated if they did not. So kind of like
correct. Absolutely. Yeah, you don't need to do a full knee exam on them. You just got to make sure you get them reduced. You can maybe just do a little gentle range of motion just to see how unstable they are. Because if it's like a posterior dislocation, you flex them to like 30 degrees and they're popping out, then that's when you think you probably need an X-fix for it, right? But as long as but that's really all I do. I don't worry about like the Lockman or dial test, God forbid, or anything like, or a pivot shift or anything like that. So don't do any of that stuff. Right? Okay, good. Okay, excellent. Okay, so then, now it's been a couple of months later. The patient's out of their X-fix. They come in, they're ready for your sports expertise. Okay, so we're going to go through this kind of compartment by compartment. So first we'll start with the medial knee. Okay, so the anatomy of the medial knee. So when we're looking at those medial structures, there's 3 layers to the medial side of the knee. Okay, AJ, can you tell me what those 3 layers are? Muted.
The superficial layer. So your superficial MCL. Just telling you your strongest layer.
So, okay, so first layer is the sartorius fascia. So when you guys are on sports and we're doing our hamstring harvest for an ACL, we'll go through each of these layers. But the first one you see on the medial side is the sartorius fascia. And this is a favorite question by most of the sports attending. So take notes on this. And then between layer 1 and layer 2, this is where your hamstrings are going to be. So that's where your pes sits. Gracilis, semi-T, and then the saphenous nerve also sits there, usually kind of like on the proximal edge of the gracilis. And then deep to so then this is where the layer, we go through the sartorius fascia, and then we get our hamstrings out. And then underneath that, you're going to actually see the superficial MCL, okay? And that kind of blends in with the posterior oblique ligament and then the semimembranosus. So when you're harvesting the hamstring for an ACL, you usually see the MCL, nice shiny structure right below it. And then layer 3 is the deep MCL. So, and then that's where you get into the capsule. But essentially, this is just very classic anatomy that's frequently tested. Layer 1, 2, 3, and then the hamstring tendons between 1 and 2. Okay. And then this is a great paper by Leprade back in 2007, looking at the anatomy of the medial aspect of the knee. This was in JBJS. And then there's 2 main components. It's the MCL, which includes the superficial and deep parts, and then the posterolateral corner, which includes the posterior oblique ligament. So the POL will show up on your OIT exam sometimes in terms of the function. And we'll go into that in a second. But the MCL, you got the superficial parts, which attaches proximal to the medial epicondyle. And then the tibial attachment, there's the proximal one where it blends in with the semimembranosus. And then distally, it goes all the way 2 to 3 centimeters distal to the joint line. So the MCL is actually super long and it's quite broad. So when we're doing like an MCL repair, sometimes that incision is going to be for the tibial side much lower than you think. It's not going to be right next to the joint. But the deep part of the MCL, this is actually blends in with the medial capsule. So this part is actually pretty thick and right around the joint. And then there's meniscofemoral portion that attaches deep to the medial epicondyle, and then a meniscotibial portion that blends in with the plateau. So the deep MCL is a lot shorter, and it's kind of where the knee capsule is, but the superficial one is a lot broader. But usually when you have an MCL injury, it's more in the superficial part. That's why you still have a lot of stability from all the other structures that'll allow it to heal. Okay, so here's a good diagram. This is from that same paper. So make sure you guys take a look at this diagram before you take your OITs, because there's almost like one question or two questions on where this anatomy is on every test. So some of the things you're going to look for, you've got the adductor tubercle here, and then you got the MPFL and then the medial epicondyle. So the MCL is lower than where the MPFL is, and then the posterior oblique ligament, and then you can see distally how far down the superficial MCL actually goes versus the deep MCL. Okay, so this is one of those kind of last minute study tools where you just want to cram it a little bit, and then this also shows up where you have that lateral view at the x-ray, and then you've got all these points and they say what are these structures. They just pick a random one to ask about. Most commonly asked about is the MPFL, which is kind of right above the line there at Schottle's point, right above Blumenstadt's line, and then right below it is the MCL right here, and then just posterior to the medial epicondyle. So this is also something to just kind of look at before your exams. Okay. And then, yeah, gross anatomy wise, this is what that kind of looks like. You've got the deep MCL here, and then they've already reflected the superficial MCL, but the deep MCL kind of attaches to the medial meniscus in the capsule as well. Okay. And then the posterior oblique ligament. So this is a fibrous extension off the semimembranosus, and it's got 3 arms, superficial, central, and capsular arms. And it is a restraint for internal rotations. I've seen that question show up every now and then. What does a POL do? And it's to actually restrain against IR. Okay. And then here's what that looks like. Here's the POL. So you can see it kind of blends in with the superficial MCL, and it also attaches to the semimembranosus in the back here. So it helps a little bit more with rotational forces. Okay. Okay. All right. And then for the MCL injury classification, grade 1, localized tenderness. So that's where when you do a valgus stress at 30 degrees, there's less than 5 millimeters of opening. Grade 2 is where it goes 5 to 10, 6 to 10. Grade 3 is a complete tear where there's more than 10 millimeters of opening. Okay, and in terms of the exam, you can do it both at 0 degrees and 30 degrees. 30 degrees isolates the MCL better. At 0 degrees, you're also going to have the capsule and the POL, so it's less likely you're going to get valgus laxity at 0 degrees. But if you do have the valgus laxity even at 0 degrees, then that's a major injury. That's going to be at least a grade 3 MCL. Okay. All right. And then you can also use stress tests for the MCL. So sometimes you can't, on x-rays, it might gap open if you do it. Much less common for us to do that for the knee versus like the ankle. And then, but these are things you could potentially see on radiograph is the Pellegrini stiata lesion, which is calcification at the site of the femoral insertion. So this, if you see this on an x-ray, this means that they've had like an old previous MCL injury. So this is like an old MCL femoral avulsion, and they've kind of scarred in there a little bit. So sometimes, yeah, with this knee, with these knee dislocations, they'll come in a clinic a few months later, and you'll see this on their x-rays, and then you know they've had a previous MCL even without an MRI. Okay, so that's a kind of pathognomonic lesion for an MCL injury. Okay, so treatment for the MCL, most of the time it's non-operative. So you've got grade 1 and grade 2. So these are non-operative. They heal very well. It's quite vascular, and there's a lot of stabilizing structures, so you can leave those alone. And then there's quite a bit of difference in terms of the rehab. For most grade 1, you can let them weight bear as tolerated. And then some people won't brace them. Most of the time we do brace them, but you'll want to brace them for like 1 or 2 weeks, and then usually people can go back to their activities. For grade 2, you'll usually put them on crutches, but they could be weight bearing as tolerated, but with crutches to help modify their activities a little bit. And those take longer to heal, like 2 to 4 weeks. But we still seldom operate on like grade 2s. Really, grade 3s are the ones where we operate, and it's very, very rare to have an isolated MCL tear that's a grade 3. If you have a grade 3 MCL, it's almost always in conjunction with either like an ACL or PLC or something, or PCL or something else with it. So usually what we will operate on those, but it's because we're also doing surgeries for the other parts. So you can give them a try. So if you have a grade 3, you can always give them a try of non-op treatment, but a lot of times you do need to fix those just because of the associated injuries. But usually if you do try to brace them, it's going to be for 6 weeks, and then you just do a reconstruction later on. But now we're probably a little bit more aggressive. If you really have a grade 3 with more than 10 millimeters of opening, we're just going to do surgery to repair it before trying to get it to heal. Like some of the older data from the 80s are a lot more conservative, but I think now we're more and more aggressive about these bad injuries. And then distal injury, less healing than proximal. So that's an important fact, that if you have a femoral avulsion, it's more likely to heal versus a tibial sided injury for the MCL. That's a very common question to ask, is if you have a MCL tear at the tibial side, there's less vasculature, it's much less likely to heal itself. Okay. Okay, good. And then, yeah, grade 3, sometimes you can have a Stenner lesion in the knee where it kind of flips over and gets stuck there. So this is kind of like an MRI of that, where you would just go in and do the surgery right away, because that's not going to heal very well. Okay. And then if you have a combo, ACL and MCL, okay, there's a lot of like gray areas on what to do for these, and it's very like case dependent. But a lot of times we'll try to give the MCL time to heal. So right now we're seeing a lot of ski injuries. A lot of patients are coming in with a full ACL tear and maybe a grade 1 or 2 MCL. And what we'll typically do is we'll put them in like a knee immobilizer or hinge knee brace, and have them work on range of motion for their ACL, but that'll also give time for the MCL to heal. And the majority of the time, like when they're ready for their ACL surgeries 4 weeks, 6 weeks later, the MCL has healed quite well, and then we don't have to do anything for it. So it's very seldom that I actually have to do an MCL repair at the same time as an ACL reconstruction, just because it heals very well. Okay, but sometimes if they're come back for their ACL and the MCL is still loose, then you can just make a direct repair for it with suture anchors. Okay. Okay, so let's see, we got a case here, 28-year-old, okay, MVA, closed head injury, ICU stay for a long time, but he can't walk now that he's better and he's back to doing things, but his knee is problematic. Okay, so you get x-rays here. Okay, who is the poor soul I'm gonna pick on? I think Dr. Charlie Kogan is in need of a question. What do you see here?
So you can see a significant amount of HO that has developed on both the medial and lateral side, and the posterior joint capsule all the way around. It's pretty bad.
Is that surprising to you with his history?
No, a head injury is kind of classic for HO formation, and with the persistent knee pain, it's almost like a Pellegrini Stieda on steroids or something like that. So
yeah,
high concern for multi-leg.
Okay, good. So what do you want to do next? You just saw him in clinic. He's got these x-rays.
Probably some more advanced imaging, so MRI.
Okay, let's see if we have that. Oh yeah, I got you one more view. What do you think of that?
Nice. Yeah, so he's also got, we know he's got, I think, although that is, so I guess it's a medial dislocation. of the
I
patella?
think it's lateral. Yeah,
It is lateral. Okay.
Yeah.
Okay.
So you can see on this one, it looks weird, right? That patella doesn't look very normal on that lateral
Yeah.
view. So it clues you in a little bit. And then, yeah, this is lateral. So this is the medial HO that we saw like here. Okay. So what do you call this? Yeah.
So yeah, patellar dislocation, concern for an MPFL tear at least, and potentially more, depending on his exam and what the MRI shows.
Okay. Okay, good. So let's get an MRI. So we got a chronically dislocated. Oh, oops, did I not put that MRI in? Okay, well, MRI looks trashed. So everything's torn, MCL's torn, MPL is torn. He's got this chronically dislocated patella, and then chronically torn MCL. Okay, he's also got some ligamentous injuries, but in terms of the ACL, so it's ACL, MCL, and chronic patellar dislocation. Now he's a pretty big guy. He's not really doing any sports. He just wants to be able to walk. Okay, so this is kind of a tougher kind of treatment plan. Marcus, what do you think you would want to counsel the patient on in terms of his treatment options? Yeah.
I should have waited to turn my video back on. Sorry, and how long out is he now that we're talking to him?
Let's say about a year-ish from his initial injury. Yeah, it's been quite a while.
So we're out of bed, we're out of the hospital.
Yeah, he's walking with he's got a walker. Yeah.
Okay. And then did we have a most recent exam? I imagine that he gaps wide open for like valgus stress and
Yep.
Okay.
Grade 3, let's say grade 3 valgus stress, and then the kneecap's just sitting to the lateral side. Yeah.
So I think the first thing you need to address then is his patella, because if you're going to do anything else, you need his patella in the right spot. I've never dealt with a chronically dislocated patella, but I imagine there might be some sort of, we have to do an open procedure just to get it back in place. I'd want an MPFL reconstruction at the very least. And then if we have any sort of axial imaging, we could also see if there's anything else we need to do at the same time in terms of tracking, but it probably just got knocked out with his initial injury and it has been living out.
Yeah. Yeah, so I think that's a good plan in terms of prioritizing. So he's got this chronically dislocated patella. That's why he can't really walk. So he can't flex his knee because it's just sitting outside of the groove. So the first thing you got to do is get that in. And then his MCL is just so lax. You also probably want to reconstruct the MCL at the same time. And then the ACL, you can always go back and do at a later time if he wants to do sports. But the first thing is to just get him walking. So right now he's got everything scarred in laterally. So you can go in there, open or lateral or arthroscopic lateral release, and then an MPFL reconstruction because that ligament's chronically torn now, and then an MCL reconstruction. Okay. So that's what we did for him. So this screw here is for the MCL, and then this plastic, well, there's a plastic screw in this tunnel here, that's for the MPFL, and these two anchors are for the MPFL reconstruction. And then we also did an MCL reconstruction on top of it. So we released it and got that back over. And then the MCL, we got a screw here, and then all suture anchors at the bottom. So this is what that looks like. So medially here, so here's the MPFL, and then you put in, we use like a hamstring graft here. So you've got it anchored down into Schottle's point, and then you've got two tails of it. And then that's why there's two metal anchors here for each of the limbs. And then that helps reconstruct the MPFL and hold the patella centrally. And then you've got the MCL running underneath it. So you got a deep, and we're essentially reconstructing the superficial one. So we got a deep attachment at the medial epicondyle, and then running all the way distally on the tibia here, 2 to 3 centimeters below the joint. Okay. Yep, so that's what we did for him. So that's kind of like a medial knee bad trauma where you would actually do something for both the MPFL and the MCL. And then let's go through, I'm gonna run out of time, but let's go through some of these other ligament injuries. So the PCL, okay, we got two bundles here. We got the anterolateral bundle, it's the opposite of the ACL. So the anterolateral for the PCL is larger and it's tight in flexion. And then there's the posterior medial bundle, which is tight in extension, okay? The different bundles in the PCL actually can be a good reason for reconstruction of a 2-bundle reconstruction in terms of the PCL versus a double bundle reconstruction for an ACL. So we'll talk a little bit about that later. But biomechanics for the PCL. So it's a primary restraint to posterior tibial translation at 30 and 90 degrees. And so this one, really the posterior drawer test is a really good test for it because you'll see a lot of laxity with it. And the main trick here is to not confuse posterior drawer with anterior drawer, because a lot of times you'll think, oh, they've got an ACL, but then if you see that the tibia is actually sitting posterior to the condyle when the knee is flexed, that's when you want to think a lot more about the PCL injury. Okay, let's see here. And then, yep, so history, usually it's going to be a flexed knee with the foot in plantar flexion. Okay, so it's not dorsiflexion, it's foot in plantar flexion for the PCL. So hitting on some of these main points, there's not always like a clear pop like in the ACL injuries. So sometimes these can get missed pretty easily. And there's a fusion, but it doesn't always swell up as much as an ACL. So these are sometimes kind of more subtle injuries, okay? But they do feel pretty unstable, especially with the knee bent, okay? And then when you have a chronic PCL injury, the 2 main compartments that you have all the load in is the patellofemoral compartment anteriorly, and then the medial compartment. So I've seen a lot of test questions where a patient has a chronic PCL injury, which areas are more likely to have cartilage wear, and then that's medial compartment as well as patellofemoral joint, okay? All right, and then, yeah, it's very commonly associated with posterolateral corner injuries, knee dislocations. Sometimes you can get an isolated PCL, but usually it's in association with other things, okay? And then classification, just very similar to the other ones, 0 to 5 for grade 1, 6 to 10 if the tibial plateau is flush, and then a positive posterior drawer more than 5 millimeters. And then grade 3, you can't have an isolated PCL that has a grade 3. If you have more than 10 millimeters of posterior translation, the knee is really unstable for that, okay? And then if you do non-operative treatment, you can do that for 1, maybe 2, and depends on their activity level. You just work on, let's see, what main muscle group do you want to work on for a PCL injury? Jen O'Donnell, this is a good question. If you're trying to treat a PCL tear non-operatively, yeah, what do you want them to focus on with rehab?
So I think with a PCL, then you want to keep it in a type of brace where you have the tibia brought forward more.
Mm-hmm. So which muscle group does that though for you when you're rehabbing it?
Yes. I think you'd want to balance kind of both quadricep and hamstrings, strengthen both of those.
I mean, you really want to focus, usually when we write the prescriptions, I mean, they're going to do both, but you want to focus on quad strengthening. So if you're more quad dominant, then you're going to have that anterior force to help stabilize the PCL, okay, in terms of like the kinematics of it. So usually when we say rehab especially for non-op PCL, we want to focus on the quads, okay. So that I've seen that question show up on tests too. And then just like Jen said, non-operative, you're going to put them in a brace, a functional brace to prevent posterior translation. And then focus on quads, and then add hamstrings as well once you have more range of motion, okay? And then 8 weeks at least for non-operative treatment. And then you want to watch out for those patellofemoral degeneration and medial degeneration, okay? All right. Okay. And then in terms of surgical treatment for it, there's 2 main kinds. Okay. So there's an arthroscopic technique where you drill bone tunnels. And then there's an open technique. This is called the tibial inlay. So this is where you have a posterior open approach to the knee, and then you basically put a screw fixation without the tunnel. So what's the criticism with using an arthroscopic tunnel technique? So this is kind of a tough one. Okay, I'm going to pick on people that aren't on camera then. Tiffany, are you there?
Yes, sorry, I'm unmuted.
That's okay. What's the critique or the problem with doing an arthroscopic PCL reconstruction with bone tunnels, like in this diagram?
So if you do a transtibial arthroscopic, you kind of get like that killer corner where the acute turn of the graft.
Exactly. So you can see that right here. There's like a 90-degree turn where the graft is here, and then it turns 90 to like more than 90 degrees actually, and then bends out this way. And that's just a lot of stress on this graft here. So it can really stretch out, and they call it a killer turn. If you do the inlay technique, you're kind of direct here, then you take that big curvature out of the turn. So the theory is that there's less stretching of the graft, but then you have to do a posterior open approach to the knee, which is not fun at all. I did some of these during residency, and it's very hairy. Okay, and then in terms of biomechanics, so this is at UCLA where I did residency, and they're huge on the inlay technique, and biomechanically it's much stronger than the killer turn. Okay. But then in terms of like subjective or clinical results, there's no real difference in terms of patient outcomes or subjective or clinical exams. Biomechanically, it might be different, but clinically it hasn't been shown to be too bad. Okay, so here's another case: 17-year-old football player, acute traumatic knee injury when it was tackled. Okay, so let's see here. Joey, what do you think about this piece, this MRI?
Yeah, just trying to trace the, the dark PCL there all the way up to the femoral insertion. It looks like it may have a volst off of the femoral side there. So
yeah, so that's a great pickup. So
looks congruent though.
Yeah, so you do see the PCL ligament is here, right? But it doesn't reach the femoral side, okay? But you do see it's not a mid-substance rupture. It looks like a femoral avulsion, right? And then you can see that here as well. Here's the ACL, here's the PCL, and then it's there, but it just doesn't reach the bone. Okay, so that's a great pickup. And then, so this is what we saw arthroscopically. So that was the ACL, and then this is the PCL, okay? So you can see that it's avulsed off the femur there, and the ligament itself looks pretty good, okay? So what would you do in this case, okay? Who's there? Steven Garcia, are you there?
Yeah, I'm here.
Yeah, what would you do surgically? You're in the surgery now, you just probed it and saw this.
And we only found this injury.
Yeah, it's an isolated PCL avulsion. Yeah.
I mean, what was his exam for? He was great.
Well, he's got a grade 2 PCL. He's an 18 whatever year old football player. He wants to go back. So what are your options for treatment here? You found this, I mean, you knew you're going to do surgery, but what are your surgical options, right? Reconstruction, is there anything else that you could do for this versus just taking it all out?
And you could repair it as well if it bolts off. The PCL has a little bit better healing properties than the ACL.
Yes, good, exactly. So for femoral avulsion, you can actually repair this, okay? So here what we did was we drilled a tunnel for it and then opened that tunnel up a little bit more. And then we're just passing sutures through the femoral stump of it here, and just do some locking sutures, multiple sutures, just get a good bite of it. And then you can feed those sutures through that tunnel and basically tie the PCL back onto the femoral condyle. So for like a femoral avulsion, you can actually directly repair the PCL and it'll heal pretty well. Okay, so here, and we're tying it down. You can see how that reduces that PCL back to the bone there. Okay, and then, yep, and then here we've tied it down. We're probing it. Everything looks pretty good. So it works pretty well, and this guy went on to heal quite well. Let's see here. And then this is Tiffany's paper. Tiffany's still here, right? So she helped us write up this technique where we're drilling it. Now this guy also had a root tear, so we also repaired his root, but you can see just the button on the outside in terms of repairing the PCL. It came together quite well, okay. All right, now how about this one, chronic PCL injury? So here we're doing a posterior drawer. So that's the ACL, and you can see that as we're doing the posterior drawer, it's quite lax for the ACL. And the PCL, you can just barely see it. It's kind of there's some scar tissue there, but there's really not much going on. So here we're going to reconstruct it. Okay, so when we reconstruct the PCL, we're going to put the tunnel in the back. So I like to do these arthroscopically. And then we'll also drill that inside out femoral tunnel. And then the hard part is passing the graft, and there is a little bit of a killer turn component. So here we're passing that PCL graft, and sometimes you're kind of sliding it back and forth just to get that around the bend. Okay, so we're kind of sliding it back and forth just to get our pass set up. And then once you pass it, then usually we use an allograft with a bone plug on the bottom here. So I try to take that bone plug as close to the surface as possible. So then that way the ligament is actually here. So the ligament's not in the tunnel, and it's only the bone plug all the way at the tip. So then you take some of that killer turn out of it. Okay, and then you can fix the ligament with a metal screw. And then afterwards, this is us probing it, and then you can just do another plastic screw is what I typically use on the femoral side. And then now when we do the posterior drawer, you can see the ACL's on tension and there's not so much laxity in it. Okay.
I have a quick question.
Okay. Yes.
In terms of what you're using for the graft, Dr. Lanzine was saying for like MPFL that people typically use allograft, and then for ACL, I know people usually use autograft. Is there a preference for PCL?
Yeah, so PCL you usually use allograft as well, because you need something with a bone plug. So usually, and it needs to be a really long graft because the course of that is really long, and you just don't have anything like that in your body. I mean, you could potentially use a quad graft, but even that might not be long enough because it needs to pass all the way through to the front. And because if you do like a patellar tendon BTB, it's going to be way too short for the PCL. So just because of the anatomy of it, it doesn't lend itself very well to autograft. Okay.
Got it. Thanks.
Yeah. Okay. And then so this is what the X-ray looks like afterwards. You have a screw pretty midline for the tibial side of the PCL, and then on the femur side we just use a plastic screw, so you don't see much there. Okay. Okay. Here's another case. Okay. Okay. So that's the ACL here. Okay, so it looks like you got an ACL tear. And then Alex, what's this part? Alex?
Yeah, sorry, I'm still here. I'm trying to think through. She said that that was the ACL.
So here, you're probing the ACL. That looks torn? Yeah.
Yeah, agreed.
Okay, and then what about this?
This is more anterior in the notch. Trying to think of what is there anatomically.
What section are we on for this talk?
I guess we're on knee, like ligamentous injuries. I guess are we looking at the back of the knee? That's what I'm a little.
Yeah, this is just you haven't had sports yet. Okay, never mind. Okay, fine. Okay, this is the ACL, and then that's the PCL. So this is a mid-substance PCL. The section we're on is PCL within the knee. Everything you said is correct, but I'm looking for more specifics. I'm just joking. Okay, but so this is a mid-substance rupture. So this is something that we can't repair back, right? So this is something we're going to need to reconstruct. So here we ended up having to reconstruct both the ACL and the PCL, and that's like a separate lecture in itself in terms of the order of doing things and how to do each one. But it is something you can do when you need to in a bad multi-ligament setting. Okay. And yeah, it looks pretty good with range of motion. So ACL there and then PCL back there. Okay. Good. Okay. Okay. Last thing before we wrap up: posterolateral corner. Okay. 3 components. Okay. LCL, popliteas, and the pop fib. So the LCL is for varus stress, and you test this in 30 degrees, just like with the MCL. The popliteas is for external rotation, but it also helps the PCL resist posterior translation when it's in extension. And then the pop fib resists external rotation with the knee inflection, and also posterior translation in extension. So these are really for rotation. The LCL for varus stress, but the popliteas and the pop fib for external rotation. And then this is also a diagram from like a very classic Leprod paper in terms of looking at the structure. So this also shows up on your test almost every time. So for like testing purposes, make sure you guys look at the anatomy of the medial and the lateral side of the knee. And you'll see that the LCL is a straight line here, lateral epicondyle to the fibula. And then inferior and anterior, this is where the popliteus tendon inserts on the femur. Okay, and then the gastrocs way in the back, and then top fib connects the fibula to this. And then there's questions of like, what's the most anterior structure on the fibula versus the most posterior? The most posterior one's going to be your biceps femoris, and then the LCL is the most anterior typically. Okay. All right, check blood flow. Yes, okay, we talked about this already. I'm going to kind of breeze through this. Varus stress. So the dial test is the main test in terms of your PCL exam, PLC exam. So this is where you flex the knee up at 90 degrees with the patient prone on their stomach. And then you look for external rotation asymmetry at 30 degrees and 90 degrees compared to the other side. So one side externally rotates a lot more and opens up compared to the other side, more than like 10 degrees more, then you wouldn't be suspecting a PLC injury. And then there's also some special tests, which we're not going to go through in detail, but I'm just going to have this slide up for your reference if you want to look at those later on. Okay, and then classification, grade 1, 2, 3. I think you guys get the trend. So for you that are interns who come on to sports, if we ask you how to grade things, it's almost always 0 to 5, 5 to 10, and greater than 10. So for whatever system it is, just memorize this and you'll be fine coming on to our rotation. Yeah, you could treat PLCs non-operatively, especially grade 1 and 2. Grade 3s, usually in conjunction with like ACL or PCL injuries, you're going to want to do surgery on those. Most of the time, ACL and PCL is the most common ones, and or either of these associated with the PLC. Okay, and then sometimes you can acutely repair, but most of the time with the PLC, you're reconstructing it. Okay, there's seldom that you're actually getting it to it acutely to where you can repair it. So there's two main ways of reconstructing it. So there's a Larson technique where you're just basically putting a graft from the femur through the fibula and looping it back up. And there's a little bit of rotation where you angle this, so that'll help control rotation a little bit, but it's definitely not as good in terms of controlling rotation as the anatomic Leprod technique, where you've got a bundle that's replicating the LCL kind of straight down, and then another bundle here going from the femur to the tibia that's replicating the pop fib ligament. So this one you can see naturally will control external rotation a lot better than this one, which is a little bit more, it's a lot more in plane with the fibula. So rotation, it's not going to do as much for. This one's just way harder to do, the Leprod technique. Okay, so here's another, I think, yeah, last case. So this guy comes in here with an MRI, full ACL tear here. Okay, and then PCL looks good. And then when we're looking for an LCL or PLC injury, we're looking laterally. So you can see here, laterally on the coronal view here, this is all torn. So you don't see LCL fibers going from the femur to the tibia. So that's completely torn in that area. Sorry, not tibia, fibula. And then intraoperatively, so ACL tear. So we just reconstruct that first. And then for this one, we did a Larson technique. So when you're doing PLC, you want to always find your perineal nerve first. It's going to be below the biceps, and you want to tag that to make sure that you don't get it at all during your dissection. And then you put in a fixation point on the femur, and then you loop your graft across the fibular head. So it looks kind of like this. So that button's for the ACL. Here, this is for the PLC. So you have a bone block here. So these are also allografts, just because of the length of it, it's going to be very hard to use an autograft for this. And then it goes down here, and you can see the plastic interference here in the fibula here. So the graft goes from here across here and then back up, and then you basically tie it onto itself, okay, for a Larson's reconstruction. Now this would be a Leprod reconstruction, so it's a lot more complicated. This one also had a PLC here, but this one you've got 2 screws because you got 2 tunnels. One of them, this should be a little bit more anterior here in terms of the popliteus reconstruction. And then that one goes all the way across through the femur, or sorry, through the tibia, and then anteriorly here. And then the top one here just goes straight down. and then across the fibula, and then that goes back into this tunnel as well. So then you got both of them coming outside of the tibia. So it's kind of a tibial base fixation instead of a fibular base fixation. Okay, and then yeah, that's kind of a more complicated reconstruction, but that's a lot more anatomic for this. Okay, all right, yeah, but you guys will get to see some of that when you get onto sports at some point. Okay, good. So that's the talk. Any questions? We got a couple of minutes before we wrap up and transition about any aspects of the talk.
Can you talk a little bit more about how you drill the femur for a PCL? Because you said it's inside out, but
yeah,
I imagine that'd be a pretty crazy angle.
It's actually pretty straightforward because you have it's just like how we did that PCL avulsion. So so here we've got basically so you've got this outside in guide, just like this, and then it's curved out. So in this paper, there's a picture of us doing it where we're holding it, but basically this is inside of the knee, and then it curves out, and then you're holding it, and then you just make an incision over the vastus medialis, and then you put that onto the bone. So it's kind of like the gold guide when we drill our tibias for the ACL, except you flip that around and then it's coming out the femur, and then you push that button down, that bullet all the way down, and then you just basically drill across the femur. It comes out there. So that part's actually not too bad. And then it's the same thing for reconstruction. We're using the same instruments, and then we just basically blow that tunnel up to like 9 or 10 millimeters instead of just 4 millimeters like we do here with the avulsion repair. Okay.
And you use an interference screw, so you don't have to do like a flip cutter for a bone bridge.
Well, for a flip cutter, you want that if you want a closed tunnel, so that way it doesn't go all the way to the other cortex. For this one, you want it open all the way through, because the graft is actually going to come all the way outside of the skin, and you're pulling hard on it, and then you're doing an anterior drawer, and then you're putting a button, a screw to fix it on the femoral side. Okay. Now, some people will do it reverse, so you could pass the graft from the femoral side through the tibia, fix the femoral side first, pull anterior drawer, and then put a metal, some kind of screw, metal or plastic screw up the tibial tunnel. So people do it either way. Okay. All right, good. But yeah, ask Tiffany about this paper, and she'll send it to you guys. But there's good pictures on it about how to do that, and essentially it's the same thing for reconstruction.